morning, everyone. Welcome to the seminar series of Collaborative Center for Genomic Cancer Medicine. And really love to see everyone here in the WCCC building in person, as well as many attendees online today. Before we officially started, the University of Melbourne would like to acknowledge the traditional owners of the unceded land on which we work, live, and learn. That's Wurundjeri, warrior Wurrung people, as well as Benari people from the Kulin Nation. We pay respect to the elders past, present, and future, and we acknowledge the importance of indigenous knowledge in the academy. My name is Gang Chen. I'm the head of the Cancer Health Service Research Unit. Just before we started just a couple of housekeeping information. So we will have the Q&A at the very end. And if you are joining online, please feel free to put in your questions along the way. We're going back to that at the very end as well. We will have some refreshment today after the seminar, which is located outside in the purple chair area. If you know the building, if you don't know, don't worry, we will be here to guide you there afterwards. So really honored today. We would like to introduce our speaker, Professor Paul Scuffham, who is from the Griffith University. Professor Paul Scuffham's research focuses a lot on understanding or investigating value for money for the healthcare interventions, and in particular on the translation into the health policy. So he is a fellow of Australian Academy of Health and Medical Science, a chair of his advisory committee, is also the committee member for NHMRC Research Committee, MRFF, NHMRC Public Health and the Health System Committee. So Paul has a lot of great researchers, more than 500 peer-reviewed publications and commission reports. But we won't go to the original research today. He has a lot of research actually very relevant to our center, focused on genomic cancer. But for today, we're going to looking at also equally and probably really important questions, the health research funding landscape in Australia. So really great to have you here, Paul, today, and floor is yours. Thank you.
Thank you, gang, and welcome everybody. Pleasure to see you all. So I'm going to run through. It's all working good. I'll use my glasses if you don't mind. I'm going to give you an overview of demand for healthcare and why research is important, and what we spend on research, why we spend that much. Then I'll talk a bit about national reviews, what's happening in the investment in research and development at the moment around the country. This is really topical, and there should be some changes, policy changes by the end of this year, but might take a couple of years to implement. And I'll talk a bit about those committees, NHMRC, MRFF, and what they're doing and where things are at and what's been happening in that space. Demand for healthcare. So we know that population is increasing. There's substantial population growth, and here we can see, hopefully this works. Not very well. So you can see the red line there is the projections for population growth over the next several years. It's over the next 40 years or so. But all that time, the black line is what has happened. That's the actual population growth. So there's been substantial population growth in the country, and it's going to continue. Life expectancy has also been increasing. It's increased more for males than females since over the last 30 years, and is leveling out somewhat, but females still have a great life expectancy compared to males, but much better than what it was. It's at least 6 years different between those two groups. 6 years change over the last 30 years, which is great. Fertility, that is something of interest because it's declining. So even though we've got population growth, we've got a declining fertility rate. And that first dotted line, the green one, is what the projection was back in 2015. That's what they thought would be happening. And that was the minimum estimate from the ABS, Australian Bureau of Statistics, and the actual, what happened after that was much lower than what they predicted to be the minimum fertility rate. And you can see what's happened there. And then there's projections those three lines is high fertility, medium and low fertility. And given the current trend, I would put my money on low fertility continuing and getting substantially lower than what it is now. Now, it's interesting what's happening in that fertility rate. It's not that family size is changing. We're finding when you look into the details, it's that females are tending to, there's more females tending to not have children, but family size is still roughly 2.2 kids per family. So those who choose to have children tend to have 2 to 3 kids, some have 4, but there's more people choosing not to have children. So putting all that together, we end up with what we call a dependency ratio. This is the ratio of people in the workforce or potentially in the workforce. It's developed by ABS. It's fairly crude. It's just a measure of those aged 16 to 64, potential working age, compared to those under 16 and those 65 and over. So potential dependents. And we can see the number of people working to support those who are not working, not in the workforce. And that is increasing substantially. So what it meant was there's almost one person in the workforce supports 2 people not in the workforce. And that ratio is increasing over time. It puts a lot of strain on the economic system, on the welfare system, and so forth. As well as putting strain on the health system. So what have we been spending on healthcare? You can see this. I need to make my screen a bit different so I can see it better. Sorry about that. So the black line on top, that's total health expenditure, just over 250,000 million or 250 billion we spend in total. And the vertical bars, what's happened over time to different sectors, hospitals, primary health care, specialists, capital expenditure. You can see research there, that little blue bar, that's how much gets spent on research for healthcare, and it all adds up. But certainly hospitals is the biggest source of where the money goes. If we break it down into disease areas, we see that there's been changes over 10 years, 2011-12 to 2021-22. Now cancer and other neoplasms is now the biggest source of expenditure by disease, just a bit more than cardiovascular diseases, and pretty similar to musculoskeletal disorders as well. But that's had the biggest change in that 10-year period compared to any other condition. So much more money is going into cancer. Healthcare funding, where does the money come from? So the blue line on top is money from the feds, the Australian government. And that has hardly changed until the last year or so, where it's had risen after COVID, and it's had a big drop down to 40%. So last 2022-23, the Fed spent less on health care than they did in any other time in the previous 10 years. That's had to be compensated for by the state governments, because the state governments really fund public hospitals. And they're kicking up because they're having to spend a lot more as a proportion of their budget on healthcare for running public hospitals. And whether that trend continues, that has continued this year. We don't have the data for that to present today, but anecdotally it's continued, and it's creating a lot more pressure on state governments. And what are the drivers of healthcare expenditure? You probably already know this. I'm not teaching you anything new here by any means, no doubt. So we know it's population growth, and we know there's an aging population. So those are 2 important factors, but there's growth in services per case. So what that means is people are going to see their specialist a lot more often. If you've got diabetes, in the past you might have gone once or twice a year to get your insulin. Now people are going much more regularly, seeing more specialists. So there's a lot more provision of healthcare for people, which is great. And then if we jump to workforce, what's happening to the workforce? This is an example using the nursing survey of the workforce and the workforce projections. The same example applies, or the same scenario applies to other allied health and clinical professions in the workforce. So we can see the demand for nurses over time. We have starts at 2023, and the solid line is up to 2035, and I've extrapolated that out to 2040, so the next 15 years. That's the demand, and you can see the supply is the blue line, so there's a gap, and overall that gap is equivalent to about 100,000, by 2040, 100,000 nurses short in the country. That's a lot. We're training more, but it's not enough that's going to be trained. So all this put together puts even more pressure on the workforce, on the healthcare system. There's fewer staff. Next slide actually might help. Yeah. So what do we do? So yes, there's fewer staff. There's people are living longer. There's more demand for healthcare. We're spending more on healthcare. People are using healthcare services more, but we've got this workforce shortage. What are we going to do? So this kind of summarizes it, but we can attempt to increase fertility rates. It's not easy. Baby bonuses don't work. We know that, which we've seen in the past, but there's other ways to do it, such as accessible childcare and return to work support after parental leave. But what we will get from that is those families who choose to have children will have more children. They might have 4 kids instead of 3, or 3 kids instead of 2. It won't encourage childless families to have children. That's a whole other decision people make. We can reform retirement, keep people in the workforce longer, offer flexible working for older adults. We can adjust income asset thresholds before the people start getting the pension. It's one way to manage it for behaviour. We can boost skilled immigration, particularly amongst young qualified individuals, ensuring job growth and avoid displacing existing workers, and increase retention of international healthcare students. That's something I think is really important. So what else can we do? So that's the workforce. We can deal with them, but we should really look at how we improve efficiency of the resources we do have. How do we utilise those resources even better? So one way is to foster and enable self-care. We can redesign services, expand roles such as expanding roles for nurses, allied health professionals. Pharmacists, we know what they're doing now. They're doing a lot more than they used to do. They can give vaccinations and all sorts of things. They can even prescribe at the community pharmacy. So there's role expansion, which is great, but that's still not going to be enough. We can reform funding models and shift away from fee for service and move towards bundled services or population-based funding. That might change how health services are organised and used and utilised. This mechanisation include more robots for this. We do it in some places now for dispensing of pharmaceuticals, but it's robotic surgery. But there's all sorts of other opportunities to use robotics in healthcare. We can leverage digital tools, and at the moment AI is the flavour of the year or decade, I think, and that's becoming more and more important and going to generate a lot of efficiencies. But will it be enough? But even so, prevention is now even more important than ever to prevent illness, prevent chronic disease, and reduce demand. So where does research fit into all of this? So there's a lot of key questions that need to be addressed. So if we're going to change efficiency one way or another, or if we're going to change the workforce one way or another, we've got to know how to change it. We've got to know what works and what's going to optimise the system, optimise functioning. So what innovations are going to best address demand and the workforce gaps? What investment is needed in research and development for effective implementation? Are we adequately preventing chronic disease as it is? If we're going to have interventions to prevent more chronic disease, what are they? How should they? We need to evaluate, make sure they're working. Are they the best interventions and so forth? So we really need research to address those questions around the research workforce, especially clinician researchers. I'll come back to that later. We need, and it's the clinician researchers who know where the problems are, who know where the bottlenecks and the pressure points are in the health system, who can come to us, academics, and say, here's a problem we've got. How do we address it? How do we fix it? And we can say, well, here's how we develop the evidence to see if it's working or not. Here's how we evaluate it and test it and so forth. And if it works, then we can roll it out on a bigger scale and implement it on a wider scale, which is what we're all about. But innovation in Australia, we know, is really uneven. It's very lumpy. And typically, as an example, we're full of iron ore, we're full of coal, we dig it all in gas, we dig it all up, ship it overseas, they refine it, turn it into steel, and we buy it all back at a premium price. They do the value add. And we do that on so many things, including drugs, vaccines, and all sorts of other things that in medicine that people here are great at inventing and developing and getting into first stage into man or something, and then suddenly it's sold off, the IP's gone, or it's licensed overseas, and then we have to buy it back at a premium. So what do we invest in health and medical research? Where is our money going in that space? And some of you might be familiar with this. This is monies from the government, from the feds directly. So there's MRFF, NHMRC grants that are two big things. Biomed translation funds, science research budgets, and so forth. Block grants is a big number. So research block grants is the monies that the government gives to universities and so forth, MRIs. It's made up of two components. One is research support packages, and the other is training packages for PhDs and scholarships. And that's a huge chunk of the monies that go into research. All up, that adds up to just under 5 billion. On top of that, there's more monies. So there's another chunk called that hospitals get directly. This is from the National Health Reform Agreement. This has been going for we're at a 6th year now. It was extended for an extra year in the last budget. 621 million hospitals get for teaching, training, and research. How that is divvied up within hospitals is unknown. They just get a lump sum, and you can talk to the chief execs and they'll tell you, yes, we've spent it all, and it's really useful. But it's worth digging into that, because there's a major component of that is around health technology assessment and unifying a system across states for health technology assessment. And I haven't seen what's happening in that space, because I don't think it's happening. But it should be happening. There needs to be greater accountability at that senior level within hospitals and health services. State and territories, their governments contribute about 1.1 billion into research for health and medical research. That's a substantial amount for states and territories, especially at the moment when they're under pressure to fund hospitals for providing treatment opposed to research. Philanthropy is about 500 million, but all up, that doesn't add up to that much. The IIHW's claim is about 7.4 billion spent on research, excluding tax incentives to businesses. But those numbers I've just read out, they only add up to 4.9 billion. If you look up other reports in Australian government, they claim it's about 5.8 billion. So there's a big chunk missing. And a report I'll come to shortly, one of the reviews said it's probably closer to 10 billion that's spent on health and medical research. But quantifying it is really vague. There's some things that are really clear, but all the other bits and pieces added up, it's poorly measured. So this is where it's going. You can see over time how much is spent on research and development. The blue at the bottom is funding from business for research, undertaking their own business, undertaking their own research and development. Then there's government, which is the dark in the middle there. Then higher education contributes quite a whack, and private and non-profit organisations a bit on top. So in 2022-23, we spent 1.66% of GDP went on research and development. That's everything, not just health and medical research. That's across the board. Should it be more than that? You can see it's been coming down. We got to the peak of 2.24% in 2007, but even then, was that enough? So we look at what's happening in the OECD, some of our peers in the OECD, and we're at the bottom of the rank. Israel's right at the top, but that's for other reasons, I no doubt, but we're still way at the bottom. Others spend more, and the OECD average is the dotted line in the middle there, and that's about 2.93%. And the argument has always been put that we should be spending about 3% of GDP on research and development in the country. That was taken one step further by a report, the McEwen report in 2013, that said of all health and medical funding, 3% of that should be on research and development, should be on health and medical research. So that 250 billion that was presented earlier, that we spend on healthcare, 3% of that should be on healthcare, health and medical research. So some reviews going on at present. First one I'm going to walk through is called the Strategic Examination of R&D, or nicknamed the SIRD report. This was set up late last year by Treasury, and they got on board the Department of Industry and then the Department of Education. And they decided that they need to look at R&D in Australia and the investment there. So these are the core people on that committee, on the panel. So earlier this year, they released a discussion paper. They called for submissions on that. They had over 600 submissions. I made a submission on that, as did the Academy, and the findings were released late July. So when I was preparing this presentation, out come the results. So I thought, right, here's some information for you. So here's the key findings of what they have reported. This is open for consultation at the moment. So they said we need to focus on the whole pipeline from discovery to commercialisation, not selling things offshore to buy them back later. We need a cohesive system that's aligned to need, and it's got to be high quality. Basic research is the cornerstone of Australia's knowledge-based economy. It's got to drive effective public and institutional investment, including tax incentives as part of the process they want to look at. And what those tax incentives are, who knows, but we'll wait for the final report. And they've got to support high risk, high reward and entrepreneurship. There's a few more things here, but public investment, they say, cannot substitute for private initiative. So they're very much supportive of industry, especially given that the Department of Industry is on board with this as a key player in this report. They are pushing for greater industry engagement across the board for all research. So, and I think we've known that for some time about industry, getting industry engaged, but this is going to be an even greater push in the future to have industry partners on pretty much everything that we do. We've got to build the talent pool, especially around STEM, and government should use their purchasing power. Governments is much bigger than any single business in this country, and they have huge monopoly power to direct how things can go. So certainly they're coming back to government to say, use your power to do what you need to do. They also want to see capital flows to support research and development and strengthen performance measurement. And one of the consultations, they did a survey of the public and people, academics, and this is the key results for that. So pretty much strong agreement for maintaining investment in foundational or basic science R&D is critical to the overall system of R&D. So that's something that I mentioned earlier that they want to support is the basic science and fundamental science. I think there's need for better coordination to manage R&D and the infrastructure, and government should play a large role in spurring collaboration across sectors. But down the bottom there, public R&D resources should be more targeted towards national priorities. That is something I thought would have had greater agreement, but there's certainly, it's got the greatest disagreement and the greatest number of neutrals. So it's got the least strong agree in that sector. So how do we compare to OECD? Here's some more comparisons, splitting it into basic research, applied research and experimental research. I think experimental we can align to clinical trial type work. Basic is the lab-based fundamental discovery research, and applied is what we do in translation of research. So we're fairly on par for applied research or translation research, how much we spend of GDP there, but not for the others. So what's the next steps with the SIRD report? The aim is they really want to increase the impact of the R&D. They're calling it RD&I system opposed to R&D now. So RD&I is research, development and innovation. So there's a series of papers to be released, and these were the tentative titles. It's meant to be 1 a week, just started. 2 weeks ago, the first paper came out. These discussion papers, there's more consultations on these and submissions, and going to be further discussions. I would hope that they would say they're going to push the government to spend 3% of GDP, or to ensure one way or another 3% of GDP goes to R&D. It doesn't have to be government spending, but it's about the government setting up the framework and incentives for that to happen. And I think there's going to be a much stronger, even greater push for industry engagement and incentives of tax reform. So watch that space. The first paper that came out is presenting a model of what they envisage. So they're looking at 10-year time horizons, at least a 10-year time horizon for their future of what are you going to do with research? Where is it going in the country? How do we coordinate this on a big scale? How do we make it sound to really put Australia front and centre in the world of having this organised? So here's their model, what it looks like. So they want to focus on a maximum of 5 important areas. They're saying defence, health, agriculture, energy, and resources. And under each of those areas, there should be 3 goals, and that's pretty much it. Fairly clear and simple, but at least 10 years. And whatever goals they have, they've got to be specific, measurable, achievable, relevant, and time-bound. It's all very high level, but it is a consultation paper, and we do need to see the final report once the consultation's finished and everything goes to plan. So they have a proposed model of greater public investment, consolidating existing programs, and stronger emphasis on translation. They're hoping to see 50%, that the government would contribute a maximum of 50% to any research, and the rest would come from industry, or the research sector, or academia, and state territory government. So that's an indication of where things are going. They want to see greater Commonwealth level coordination mechanisms to agree on these focus areas and support delivery. So each focus area, such as health, will have its own agency, will be the lead. We'll come to that shortly in the other report that's happening. They want to develop and adopt frameworks to complement the 10-year plans, so an investment framework and an evaluation framework. And for the health economists in the room, we're heavily involved in the evaluation. We don't just do it to health, we do it to all sorts of other programs as well. So we can watch that space and hope for some contracts. Finally, they want to maintain the foundational research and development. This is the basic science, given the push from public consultation to keep that going. So, but they need to lean a bit more on venture capital and so forth. The other report that's happening is the National Health and Medical Research Strategy. This has been going on for some time, and you might remember back in 23, there was a consultation around merging the MRFF and the NHMRC, and some options were presented, and people could vote and have their say and so forth, and say what they think should happen. And there was 3 different models presented, and that's all ticked along in the background. And in March last year, it was announced that there will be a new HMR, Health Medical Research Strategy. It didn't really get started until Rosemary Huxtable was appointed as the chair at the end of last year. And this, rather than having a panel of independent people, it's very much government driven. And you can see the intergovernmental committee, the representatives from each of those departments. There's quite a few departments there on this panel who are driving this. They've undertaken quite a bit of work since Rosemary was appointed. There's been an audit of the health and medical research workforce, which actually started before Rosemary was appointed. There's been a qualitative paper undertaken and an issues paper released. And finally, just last week, there was a draft strategy released. And that draft strategy, sorry, I'll jump back a step. The workforce audit, it identified that this is an interesting approach because they used LinkedIn data and AI to generate their numbers, but we've gone back to them as through the NHMRC on a number of occasions, and there's a lot more detailed data that is not in the report. But anyway, it's all there. There's almost 37,000 people in the HMR workforce in Australia. Most of those are in universities or medical research institutes. 30% are in Victoria. So Victoria's got by far the biggest workforce for health and medical research. In that workforce, 52% are female, but females only occupy about 25% of leadership positions. 40% of the workforce in universities and MRIs were born overseas, and 50% under 44. Almost half of postdocs leave research within 5 years. And those who remain in research do so because they love research. There's a good career for them, they enjoy it, and they're prepared to live on soft money to some degree. Only 34% have permanent positions. So quite a vulnerable workforce. So this graph is showing what happens. Here's our current researchers on the left-hand side, where they're based. University by far the biggest, followed by medical research institutes, so it's 69%, and the rest are scattered around various places, including clinical settings. And where do they go when they leave? So most go to government, some stay in the university, but they'll change from research to lecturing type roles or administration roles. Some move into the private sector, and some move into MRIs, but not doing research. And some go back to doing clinical work. So the second paper they released was around a consultation they did with the public on what are the views of the general public for health and medical research. Where should they invest? What are the priorities they asked the public? Where should we put our money? How do we determine those priorities? And this is what they came up with the public. So most of it, if you read those captions there, is what we'd call burden of disease type indicators. It's severity or on impact on quality of life. It's the prevalence of the condition. It's is there something useful to treat that condition? A bit around health promotion and prevention is important, and cost to the health system. So that's in a nutshell what that paper tells us. So what it means though in that paper, those with rare diseases might fall off, might be overlooked. The third paper was an issues paper. I won't go into detail there, but they came out. It's a fairly short paper, but each issue, as you can see there, they presented in 2 pages. So here's an issue. This is from another consultation. This is what they found. This is what they need to be doing. This is background reading for those who are interested. And this is the recent paper that came out last week. So a few of us have been poring over it, looking at what's going on, and they're hoping to have this all final. Consultations are open until 8th of October, so another 5 weeks. Please, I'd encourage you all to put in a submission of your thoughts, whatever it may be. And I'm hoping this will be wrapped up by the end of the year. It's probably about 80% done as it is. So I don't think too much is going to change, but there's room for tweaking it. And you can see at the top there, this is their strategy on the page. This is what it's going to look like. Once again, they have 5 focus areas, just the same as the CERT, except this is 5 focus areas within 1 focus area being health. And you can see the vision at the top there, which sounds quite good. Australia, the healthiest nation, driven by research, delivering for all. I think it's for a health and medical research strategy. I quite like that, but there might be better ways to word it. Who knows? So I'm going to walk through some of this briefly. So here's the 5 focus areas. As you can see, develop a vibrant research system and enable or embed research processes that are modern and efficient and consumer-centred, accelerate research and translation to improve Aboriginal and Torres Strait Islanders' health and wellbeing. That's a major component of this. Drive impact through research translation and innovation, and be in a position to address future needs and challenges. So key things in this developing build a vibrant research system is about priority setting and evaluating impact. And it's one of those things where you've got to measure, you get what you measure. If you, measurement is an incentive on its own to start changing behaviour. People start doing what's going to count. Also interesting that setting up a horizon scanning process, which has dropped off. We used to have a horizon scanning. It stopped in about 2010, 2012, but suddenly it stopped when the, Health Pact ceased. They want to see Commonwealth research funding unified. So this is a push to what's already been started to unify from the previous survey in 2023 around, was option 2 was the proposal that got the most votes. So unifying the MREA, which is the Medical Research Endowment Account owned by the NHMRC, and the MRFF. So merge those two, one way, merge the management of those two, one way or another. They want to grow clinical trials, grow that network of clinical trials. So not clinical trials on their own, but have that network. And I think it's that network that's really important. It's always hard to recruit patients, especially with rare diseases or rare cancers, from 1 or 2 sites. You need the whole country involved. So there has to be a system to be able to do that. And often it's more than one country to be involved. Building trust in consumers, I think that's really important, especially following COVID and a lot of the misinformation that's been coming up. So that's a key area to focus on. And once again, the rural, remote and regional, or RRR as they call it, in research, because that's quite different to the research that's undertaken in the major cities. They're quite different needs. Slide here has gone out of whack, so I apologise for that. I'm not sure what's happened there. But this is really accelerating research translation. It's all about, for the one way or another, it's about building capacity and research on and for Aboriginal and Torres Strait Islanders. So there's quite a bit of detail if you pull out the draft report on that. Then they want to drive impact through translation, and you can see what's there. So it's embedding research, supporting sovereign capability and so forth. And then position ourselves to be ready for future changes. There's a couple of enablers they talk about. So workforce is one thing, developing a workforce plan. So we need a plan for our workforce, what's going to happen. We know that it's really tough being a researcher, being a postdoc, especially being an early career researcher, developing clinician researchers. There's no real plan. It's pretty much homegrown. Different hospitals have their own incentives or measurements and funding and so forth, and support packages for those who want to do research. And funding is really about mapping funding to goals. The other enablers, the key thing on this slide is really the National Strategy Advisory Council. This is the governance. They really want to set up a new council to oversee the strategy and to make sure it happens. And that strategy's got to have a 10-year plus vision to drive it. Some of the metrics, yes, pretty boring slide, but they need metrics around the core values: impact, quality and integrity, equity and collaboration. And so in short, here's the vision again. Australia, the healthiest nation driven by research, delivering for all, 5 focus areas and the enablers, especially the National Advisory Council. Interestingly, from the Academy of Health and Medical Sciences, these are the core things that we've been advocating over the last 4 or 5 years. And most of these, all of these are in the draft report. So they've picked up on these, which is great to see. Just shows the impact, and we do have meetings with Rosemary Huxtable from time to time. So there is a strong link there. So certainly influential. But what's wrong? What's wrong with this report, the strategy so far? I think it's more of the same. We're pretty much doing all these things. It's developing. It's just a bit more coordination at a high level. MRFF and NHMRC are coming together one way or another. They've started trying to do their reporting, report on the same metrics the same way, and all sorts of other things. I'll come to that shortly, what's happening in that space. I don't think there's any clear strategic support for human infrastructure that supports research. There's a bit of talk about foundational basic sciences and all that stuff. We've got to support these things. But there's nothing, a bit about clinical trials, but nothing around the people who really make it happen, who turn experiments into great experiments, into robust, high evidence, high quality evidence. And that means you've got a really good biostats, really good health economics, you've got a really good data science people involved. And if it works, you've got to have the implementation people to know, how do you roll this out? How do you make it? How do you expand it? What's the impact of it all? There's nothing much about state health department involvement in this. And state health departments are fundamental to making this work. So that's up for discussion. So I'm keen to see what's going to happen there. There's still no metrics around performance of hospitals and CEOs. And in my mind, I think chief execs of hospitals should have a KPI around research in their hospitals. That could be numbers of patients who are involved in the clinical trial, number of staff, they count publications, but number of staff involved in research, how much time is spent on research. There's a whole raft of metrics they could develop, but it's about having some high-level, simple metrics to say, what are they really doing around research? How can we make them accountable? There's no clear direction in any of this either. Nothing around, we've really got to focus on genomics, or we've got to focus on cancer, we've got to focus on digital health. There's nothing like that to show that Australia is going to be the leader in something. So there's certainly room for input and developing the strategy. So if you're keen, have a read of it, put in a submission. I will be, and so will the Academy of Health and Medical Sciences. So what's happening with the NHMRC and grants and so forth at the moment? So these are our grant success rates by state over the last 5 years. And down the bottom is WA, who complain vigorously about being always at the bottom of the rank. Victoria's #1 and has been for some time. So there's success rates, and overall 13.8% for NHMRC. Not great, but that's what it is. Here we have MRFF funding by state. And you can see Victoria gets the biggest slice of the pie, but more than New South Wales, and similar number of grants, which is the blue line, the percentage of grants, but the percentage of funding is much greater. And it declines based pretty much on population in the state, apart from South Australia versus WA. So putting these together, some people have said, well, let's look at the population base and say, right, what's a proportion of the population in the country? WA's got 10.8%, but only gets 4% of NHMRC grants and 5% of MRFF grants. Something's not quite right there. Whereas Victoria is 25% of the country's population, gets almost 42% of grants for NHMRC and MRFF. So if you're going to apply for a grant, do it from Victoria. So the message there. But why is that happening? We can slice and dice the numbers from NHMRC and MRFF, by state, by rural, RRR, rural, regional, remote, by sex or gender, whatever way you want. There's a whole range of things. So sliced it by basic science, clinical, medical, health services, research, and public health. And we can see MRFF is fairly even across the 20% for most. It's the success rates for across the board pretty much. Percentage of funds, basic science, the MRFF doesn't fund much in the basic sciences. They don't get many grant applications either. So that's the way that goes. But the bulk of it goes in clinical medicine. NHMRC have excluded CREs because they weren't out when I did this, and synergy grants. They distort things somewhat, but you can see the percentage, their success rates. Health services research, 7% overall. And if we go to the right-hand column, we can see the ideas and investigator grants combined, 6.5%. This is for 2024 data. Well down, pretty tough. The basic science for ideas and investigator takes up 53% of the funds of those grants. So a big slice goes there. So what's wrong with the NHMRC, MRFF have been criticised for a number of things. Pretty much that it's seen that the NHMRC fund bench science, which on one hand they do, you can argue that it's a criticism, and health services research misses out immensely. But then people argue, well, the MRFF will look after you for health services research, but it's no different to the other grants for the success rate. So it's not a preferential thing at all. Ideas and investigative grants, they're the real flagship of the NHMRC. And as we've just seen, that the bench scientists get the biggest slice of the pie of those types of grants. And they go for major developments, great fundamental things that lead, take 30 years in the development, 17 years actually for some of these things like spray on skin to get from invention to FDA approval. It's just a long time, but it happens, but it's great stuff to invest in. And that's where it goes. That's what they want, big ideas. Does the MRFF address building capacity in health services research and public health research infrastructure? Not really. It's pretty hard to say that these are fairly much siloed. There's little focus on building that infrastructure, especially in health services research. And the problem is Category 1 funding isn't sufficient in isolation, especially given the low success rates. If someone gets a fellowship, an NHMRC fellowship, very prestigious, but it really covers 50% of the salary. The university or medical research institute has to find the other 50% from somewhere. Some of it comes out of the block grants that they get, if they're lucky, but DVCRs often argue that all that money spent, it goes on building, computing, library, all sorts of other facilities. They can't give it all to support your salary. So it's a tough gig. But there's also a huge amount of waste in preparing grants. If there's 13.8% success overall, the amount of hours, days, weeks of teams of people spending to develop a grant, and your chances are you're going to be unsuccessful. It's a real disincentive. And people have asked, why is there so much geographical disparities? Mainly WA is asking this, but it's being looked into, especially at the NHMRC and the scores, as there's some systematic bias going on with scoring. Is there some area where grants are consistently falling down when they judge grants? There's a bit of work going on behind the scenes, but other notions is people have poor track records in WA. I don't think so, but this geographic isolation, state investment has been cited as one of the causes as well. If you have high state investment, people are going to rely on the state to provide your grants, to provide your funding, so that not as much effort goes into the national grants. Who knows? Unconscious bias always comes up. But the question is, does every university need a cyclotron? Does every city need a cyclotron? One in Australia is enough. It's a huge cost for these things. How should we manage these things? And it's really concentrating high cost research in a few places. And what we've seen over the last 30 years in my time is pretty much now every town, I don't know what that is. No, I'm not going to restart. Pretty much every town has a university campus these days. I don't know if that's efficient, and universities are under a lot of financial pressure and strain. So in my day, you go to the big city to go to university, not down to the local. So I think the world has changed somewhat. I'm going to skip that. Just a bit of an update on what the national committees are doing. This is the structure of how the NHMRC and MRFF are currently based. At the end of last year, this was the start of amalgamating both NHMRC and MRFF to improve the management of both, so they're not having the same scheme under different names. So the NHMRC is the blue, and the MRFF is the red there, or AMRAB is what it was called, their board, which manages the MRFF. There's been the light lavender there is a number of new committees that have been set up, and the blue on the right hand side is the NHMRC type committees. Those with an asterisk beside them as the statutory committees, so people are appointed by the Minister for that. So it looks complicated, but it's really not that complicated. It will become even simpler in the future. So one committee I'm on, the Public Health and Health Systems Committee, they have a work plan that we've worked through and that's really to look at the translation strategy, to review the translation centres. These are the research translation centres, such as Monash Health, I think. So looking at the support for health services research, how is that going? So I think that's a key function. Guideline development, support for primary public health, primary care prevention, and impact on health and medical research translation. But I think the key thing is the bottom, setting up the National Health and Medical Research Strategy, is to really drive what's happening in that space with Rosemary Huxtable. The Research Committee is another committee. So there's a bit going on in the background, such as looking at priorities. How do we manage priorities? So there's been a bit of work to have that structural priority funding for females, to make sure that females and males are equally represented especially on investigative grants. The structural priority funding, something was relatively new. It's used in ideas grants as well, but it just helps to address any inequities and balance there. Funding of level 3 investigative grants is under review. There's a number of options on the table of how to manage them, because a huge amount of funding goes towards those L3s. And a lot of those people on L3s are in their late 60s. And do they really need a full salary or not? Some of them work part-time or are heading towards working part-time. So there's a few options on the table for that. Sapphire, you'll be familiar with. That's going to be changing in June 2027, or it will be offline for a month. Will they switch over to a new system, or migrate to a new system? So watch that space. But it's going to be more aligned to what the ARC use and other government departments. Much simpler system apparently, so it's streamlined, so wait and see. Synergy grants, they will be trialling an expression of interest process. I think it's a great step. ARC have an expression of interest process, but I think for synergy grants, that's the smallest grant, substantial grant, but it's the smallest numbers of applications to do a trial to see what happens. This discussion around that has been, it takes a lot of work to write a one-pager as a pitch for an EOI. You might as well write 8 pages. That's what some people have said. But it's much easier for reviewers to go through a one-page, especially focused on impact. What does all this mean? What's it going to lead to? Is this worth telling the team to take it a step further? The gender equity strategy, that's under review. Distribution across states, there's a new working party we've set up for that, as well as the RRR inequity planners in development there. So I'm going to leave you with this last comment from Rosemary Huxtable. This is from the National Health Reform Agreement that she wrote. So I thought this was very interesting. Investment and commitment to funding arrangements longer than 5 years, and research funding in health economics, evidence-based policy design and rigorous evaluation is required to provide stability and predictability of high-value health, aged and disability care. So I think it's really pertinent. Thank you.
For the really great insight, and so we got time to take some questions from the audience. We have some questions from the online attendees. We just read it out.
Yep.
Yeah. Research on chronic disease prevention often involve benefits that are only seen in the longer term. So how to best plan economic evaluation methodologically and translate findings to key stakeholders given this limitation relative to interventions involving curative care? RCTs are often unfeasible, so more use of observational or real world data or modeling. What's your thoughts on that?
I agree with that, and the economic roundtable that you would have heard about, that was certainly that there was a discussion paper based on, it had an unusual title, but it was very much focused on preventative care and setting up a system to manage funding for preventative healthcare interventions. Hopefully that will get some legs. That was underwhelming, but the idea was there, and I thought this is a start that needs to focus on that. I think the health and medical research strategy should also have that embedded there. They're looking at a 10-year plus horizon, as is the third, looking at a 10-year plus horizon for what are we going to do. Prevention really needs to be front and centre in there, especially given what I was saying at the start about the ageing population, the reducing workforce and so forth. We can do more. We can do a lot better. Economic evaluation around preventative interventions, it's really difficult because we know the PBAC, the Pharmaceutical Benefits Advisory Committee, I could say wedded to the 5% discount rate, but now that is part of the HTA review that they are re-looking at when and what discount rates should be used. Because when you use a 5% discount rate and you take somebody who lives to say 80 and apply a 5% discount rate to that, you end up with about 17 life year equivalents. So it really undervalues the full spectrum or the longevity of an intervention. And some of these interventions you need at birth or early childhood that you might not get the benefits until you're 50 or 60. We don't know, so it's fundamental that that's addressed. So that is going to be addressed one way or another through a discount rate, but that's a technical matter rather than an investment in prevention. And I think that's the investment in prevention that's needs to be done.
Yeah, thanks.
Hi, thanks. Thanks. I was wondering, like, where does mental health and also like mental health prevention stand in all of these like aims of trying to make Australia really healthy, a healthy population?
I won't commit myself to saying it's definitely in there, but I think I'm pretty sure it's in there in the health and medical research strategy. It is mentioned, but it doesn't take up a whole focus like Aboriginal and Torres Strait Islander health does.
I have a question regarding the career path for data science, because as you mentioned, there is no clear strategy for biostats person or data science person. And we often feel it's hard to lead a research grant. We are mostly walking behind. So what's your advice in regards to this point? Thank you.
I totally sympathise, and I know exactly where you're coming from because health economists is very hard as well. But that's why I mentioned that there should be something around supporting the human infrastructure for clinical trials and healthcare interventions to test and develop that evidence. And that means supporting the workforce and really developing that workforce. So I'm hoping that that will get some legs, and it will be a key feature of the health and medical research strategy. It needs to be, we need to be more embedded in hospitals and healthcare rather than universities, but some universities work across both, which is really essential. And I think that's where all this is going, that people should be looking to have joint appointments and working at one foot in both camps. So career path, data scientist, biostatistician, usually they're on a grant application, but not a CIA. But they're fundamental, but it's about keeping that traction going, collaborating with whoever, and it's an essential role. It's got to generate enough income to support your salary and to grow a team. It's not just your own salaries. You want to grow. You've got to support the next generation. Fingers crossed that something will happen in this space.
We've got 2 questions. I'll go from one from online first and go to one. So how can busy clinicians be supported to have dedicated time for research in the overwhelming health service?
Oh, that'd be great. that would be great. And that's what I think needs to be in that health and medical research strategy, that it should be one of the KPIs for chief execs of hospitals and health systems to say, this is how much time is allocated. It might not be all clinicians get time, but some should have a decent, respectable amount of time allocated to undertake research. Registrars need to do their fellowship, and that involves usually 1 or 2 small research projects, but it's got to go bigger than that, broader than that. Consultants, people need to do PhDs. If you're a clinician, you don't have to be a medical clinician. You might be a pharmacist or a nurse or allied health professional. And if you're wanting to get a leading job in a leading hospital in Australia or elsewhere, you usually need a PhD. If you're a consultant oncologist and you want a job in Sydney, you pretty much need a PhD for them to take you on. It's that simple, but that means time, it means investment, and clinicians don't like to step away from clinical work to do a PhD, not at all. There's no money in that, and to go from a 6-figure salary to $30,000 a year scholarship, it's out of the question. They need to be supported within the hospital to undertake additional training. It's good for the hospital, it's good for patients to have clinicians who are at the cutting edge of science and knowledge. It's just got to be in there. It's got to be a KPI for chief execs, whatever it is, whatever number it lands on, but it should be in there. It should be accountable. And the same with clinical trials. If you've got patients and they can get access to a drug that's in a clinical trial that they wouldn't otherwise get access to, fantastic. They should be having that opportunity. The NHMRC does support that. It has the international collaborative grants, especially the Europe grants, it's only 500,000, but if Australia can be an arm of a multinational study and set up a site in Australia to do that, fantastic. It means some patients are going to get access to new drugs or new therapies that they wouldn't otherwise get access to. So it's definitely supported, but we need more.
Yeah.
Do I have just this one? Hi, I have a question about non-pharmaceutical intervention research or projects in which how to position a research that led to commercialization, but it's on designing buildings and cities to be healthier, and more specific at the moment that it's more on ongoing pandemic preparedness measures, in which I think Australia is lacking, but Singapore is ahead. So what kind of grant is right to kind of set up a research team around this issue? Should it be based in CSIRO just because Professor Brett Sutton is currently the director, or is it via the university? Or because the team would have Singapore government and Victoria government, hopefully, and my research is hosted by Faculty of Medicine, by an architect. I do not know how to position and what kind of grant would be right.
I'm not sure I can provide you with
what kind of commercialization output that can make it feasible for it to go on.
The output from a grant like that for commercialization would...
Commercialization, that means that it can be a part of a specialized consultancy that redesigned or refurbished, say, hospitals, cities, housing districts to be healthier and function well during future pandemics, or we can actually prevent the infection rate at certain levels, which is experimental but can be modeled using Asian-based modeling.
I think I should talk to you over lunch.
Thank you so much for the really excellent presentation. Thank you. And we will have the lunch over the blue chair area now. So please keep continuing, have a chat with Paul, and also show networking opportunities. Just mentioning quickly, next week, same time, we're going to have another seminar presented by another Paul. I think it's Professor Paul from Children's Cancer Institute. So looking forward to see everyone next Wednesday, same time. Thank you and goodbye. Yep.
Very good.